Have you ever wondered what really goes into a clinical decision about a specific drug? Today, we're going to go way beyond the textbook. We're going to build a complete clinical case file from the ground up for a drug you are going to see all the time, metoclopramide.
Okay, let's just dive right into a scenario you are absolutely going to face. You're on your rotation, you've got a patient with nausea that just won't quit, and your attending says, let's get an antiemetic on board. This is that exact moment, where the textbook slams into reality at the patient's bedside, and knowing your pharmacology inside and out is everything. So, we are zeroing in on metoclopramide. It's a real workhorse medication. We're going to put on our clinical pharmacologist hats, dig through what the core texts say, and build a drug profile that's not just for passing an exam, but for real, actual clinical practice.
So here's our game plan for this. We'll start with the basics, then get into the mechanism, follow the drug's journey through the body, talk about the big red flags, cover side effects, and then we'll wrap it all up with a practical clinical checklist. Let's jump in.
All right, first up, let's cover the fundamentals. Before you use any tool, you've got to know what it is and exactly what it's for.
Okay, check this out. The therapeutic class is simple. It's an antiemetic. It stops nausea. Easy enough. But it's the pharmacologic class, a D2 receptor antagonist. That's the real key. Seriously, that one little phrase tells us how it works, and it gives us a huge clue about the side effects we need to be on the lookout for. It's officially approved for nausea, yeah, but you're also going to see it used off-label for things like gastroparesis, really severe morning sickness, and even to help empty the stomach before surgery. It's a true utility player.
All right, section 2, the mechanism. This is where metoclopramide gets pretty cool, actually. It's not a one-trick pony. It has this really interesting dual action. So what's so clever about this drug? Well, it's got two jobs. First, it has a central action right in the brain. It blocks dopamine receptors in a spot called the chemoreceptor trigger zone, the CTZ. Just think of the CTZ as the vomiting headquarters. If you can block the signals there, you shut down the whole reflex. But it also has a peripheral action down in the gut. It boosts the effect of acetylcholine, which in turn increases gut motility. This is called a prokinetic effect. It literally pushes stuff out of the stomach faster, which, guess what, also helps reduce nausea. A dual action approach. Pretty smart.
Okay, so we know what the drug does to the body, but what does the body do to the drug? That's pharmacokinetics, or what we call ADME, absorption, distribution, metabolism, and excretion.
So metoclopramide takes this classic four-step journey. It gets absorbed into the bloodstream, it's distributed to the places it needs to work, it gets broken down by the liver, and finally, it's cleared out by the kidneys. Understanding this basic path is really key to figuring out how it's going to work in our patient.
But here, we hit a bit of a wall with our foundational books. They tell us what happens, but they're missing the really critical timing, like the onset of action or the half-life. How fast is my patient going to feel better? How long is this drug going to last? This is a perfect example of why in actual practice, you have to go beyond the textbook and consult specific drug references for this kind of crucial data. It's a non-negotiable step for safe practice.
Now, let's talk about one of the most important parts of any drug profile, the red flags. Who should absolutely not get this drug, and for who should we be incredibly cautious?
Okay, so who gets a red flag? Well, first, the obvious one. A known allergy is an absolute no-go. Then you have to look at your patient's history. Do they have severe heart disease or high blood pressure? You need to be careful. Are they pregnant? The go-to is to try non-drug options first, though in really severe cases it can be used, but only after a very careful risk-benefit discussion. And here's a big one. Children. They are much, much more likely to experience some of the serious neurologic side effects we're about to get into.
Okay, this section is so important. Every single drug has side effects, but you have to be able to tell the difference between something that's just an annoyance versus something that's a life-threatening emergency.
So first, let's cover the common stuff you'll see. Drowsiness is a huge one. Definitely something you need to warn your patient about. You might also see some agitation or confusion, especially in older patients. And then there are the usual suspects for GI complaints. Dry mouth, and it can go either way, causing constipation or diarrhea. These are the kinds of things you'll be monitoring for and managing day to day.
And then you come across a sentence like this in the text. This one line is a massive red flag. Phenothiazines are a class of antipsychotic drugs, and they are notorious for their really serious neurologic side effects. So this quote is telling you, hey, you need to be on high alert for those exact same problems with metoclopramide.
And here they are, the two big ones you have to know. On the left, you have extrapyramidal symptoms, or EPS. We're talking involuntary movements, muscle spasms, tremors, rigidity that happen because the drug is blocking dopamine. On the right, you have the even scarier one, neuroleptic malignant syndrome, or NMS. It's rare, thank goodness, but it is a full-blown medical emergency with intense muscle rigidity, a dangerously high fever, and unstable blood pressure. It can lead to complete collapse. Both of these come directly from that dopamine-blocking mechanism we talked about.
So, let's put this all together. You're at the bedside, you've got the drug in your hand. What do you need to do to be safe? This is your clinical checklist.
First, your assessments. Before you even give the drug, you need a baseline neurologic exam. How's their movement? What's their mental status like? Then, after you give it, you are watching them like a hawk. Any new twitching? Any stiffness? Any confusion at all? And you're keeping a really close eye on those vitals. A sudden spiking temperature could be the very first sign of NMS.
Next, what do you tell the patient? These are your key teach-back points. Number 1, this medication can make you very sleepy, so please, no driving. Number 2, and this is the most important one, if you feel any muscle stiffness or have any spasms or twitching that you can't control, you need to tell me or a nurse right away. And number 3, a little comfort measure. You might get a dry mouth, but we can get you some water or hard candy to help with that.
And finally, the clinical pearl. This is that little factoid you need to lock away for your exams and for your entire career. For metoclopramide, it's tardive dyskinesia. This is a type of EPS with these repetitive, involuntary movements, like lip smacking or grimacing. The truly terrifying part is that with long-term use, it can become permanent. You will 100% be tested on this.
So we've built a really solid clinical file here. We know the what, we know the how, we know the why. But what is the most critical piece that's still missing from all of this? The dose. Our textbooks gave us all the theory, but not the practical order itself.
And that really brings us to our final and maybe most important question. You've done the work, you understand the pharmacology, the risks, the benefits, so now what? As a safe, evidence-based clinician, where are you going to go to find that final critical piece of information, the exact dose for your specific patient? Because forming that habit of looking it up every single time is what separates a student from a truly safe and effective clinician. Think about it.